Last but not least, ختام مهمس. We will be listening to the last lecture presented by Dr. Najwa Abdelhaq. Dr. Najwa graduated from the Faculty of Medicine of Hamburg University in Germany, trained in several German hospitals and the King's College Hospital in London. She specialized in pediatrics and pediatrics endocrinology at the Hadassah Hospital, and currently she's the head of pediatric endo and diabetes at the Ashtari Arab Hospital in Ramallah. Her lecture will be about the management of insulin-dependent diabetes, not with insulin only. Thank you so much.
Thank you for the introduction. بديش أطول عليكم. It's a little bit difficult to talk after all the teachers and the professors that were talking before. I think I'm at the beginning of my 10-year experience. Maybe in 10 years I can give you a presentation summing up more patients. I'll take you a little bit into our pediatric diabetes world. We heard a lot in the last 2 days about diabetes medications, and now I will try and help you see how we think. You know, usually as pediatric endocrinologists, more than 80% of our diabetes patients are type 1 diabetes, and we only give them insulin. This is the way things go. So this is the perspective where we start, and this is why I wanted to introduce you this case and maybe to give you something practical for your practice, because I also know that not only pediatric endocrinologists meet type 1 diabetes children or many adolescents. This is my concentration point, but you also in other clinics you see them as well. So our case is a female patient, 16 years old. She has been known to have type 1 diabetes, autoimmune diabetes, since the age of 80 years. She also had hypothyroidism. She also had autoimmune hypothyroidism. Anemia, diagnosed to have thalassemia minor. She was overweight. She had secondary amenorrhea and a lot of social problems. The clinical picture, she was an obese patient. Her weight is 74, almost 75 kilograms at the 93rd percentile for age, height 155.4, 13th percentile, very high BMI, 31. Her physical exam revealed strong obesity, fat accumulation in the abdominal area. She had no thyroid enlargement, no bradycardia, poor skin care, feet and hands, multiple brownish skin lesions on the limbs. She had Tanner 5, puberty staging, hirsutism in her lower back, face, breast, and periumbilical, and her injection sites and tips of fingers were okay. Looking at her lab, as I mentioned before, she was anemic. She had a hemoglobin of 9, low MCV, high RDW. Her A1C 9.7, not good at all. Microalbumin in urine was negative. A reminder, she's been having diabetes for the last 8 years, so of course we had to do microalbumin. Kidney function tests, liver function tests were all normal. HDL, LDL were okay, but she had elevated triglycerides. Her TSH was high, and her 54 is low despite treatment. And of course consistent with her diagnosis of hyperthyroidism plus non-compliance. And we did a workup for a hormonal profile regarding her amenorrhea and her estradiol, progesterone, DHAS, and prolactin all were fine, as well as her LH and FSH. So regarding her hypothyroidism, you know that if we manage a diabetes case and they have parallel hyperthyroidism, you have to get the hypothyroidism in control in order to manage the blood sugar and to get better HbA1c. It goes together, so we had to address all her problems, including the hypothyroidism, of course. Despite treatment, the readings were not well. She was sleepy, lazy, she was gaining weight, and we decided to increase the dose from 1,200 micrograms to 1,400 micrograms weekly. The secondary amenorrhea, she had normal ovarian function, laboratory-wise, normal androgens. There were no lab signs of PCO. We were wondering why does she have this amenorrhea. We couldn't really answer it, but we gave her a trial of Diane, and it really helped. Within 1 month, she had a regular menses. Her diabetes was managed with a basal bolus regimen, sliding scale. We would have preferred to give her carb count, but the compliance was really low, and this is really everyday, real-time picture from the clinic. She was on 46 basal insulin, units of basal insulin, and 55 bolus of Novorapid. So we're talking about 1.3 units per kg per day for this girl, which is quite a huge amount. Nevertheless, the diabetes was uncontrolled despite these huge amounts of insulin. She had high blood sugar readings, high A1C, and increased appetite. She was gaining weight. And at one point we thought, we cannot continue raising the insulin. We've been doing this for the last months and it didn't really help. And looking at the picture, adolescent, obese, amenorrhea, hypothyroidism, we thought, how about we try and give her metformin and see maybe this can support. Although regularly or usually in the pediatric age group in type 1 diabetes, we don't really do that, but we gave it a try. So it helped. She was started on oral metformin 850 milligrams twice daily. Her A1C went down within a few months, better glucose control and no weight gain. But she had hypoglycemia. She said she's eating less, she had less appetite. And we decided to go down a little bit with the sliding scale with the boluses, not the basal, if food portions are less, because the hypoglycemia was more during the day, not during the night or early mornings. So we have here a patient with diabetes, hyperlipidemia, obesity, PCOS, insulin resistance. And again, in type 2 you always talk about it, in type 1 we rarely do. But we were thinking, so maybe this is something that we should think of. How about insulin resistance in type 1 diabetes in children? Glycemic control is most difficult during adolescence. Typical picture, they want to go to the gym, they don't, they eat chips, watch TV, lay down all the day, ignore their medications. This is how the youth are. Adolescents with type 1 are more insulin resistant than their peers, increasing their risk for cardiovascular disease. We have also to think of the long run. Although we usually follow these patients up to maybe 18 years or a little bit longer, we rarely see the complications, but we know about them and we have to remember them all the time and keep them in front of our eyes in order to motivate ourselves and our patients to do better. The insulin resistance is further worsened by the rising obesity prevalence in type 1 diabetes, creating a need for adjuvant therapies in type 1 diabetes to lower cardiovascular disease risk in pediatric group. Now, the diabetes control and complication trial emphasized that intensive glycemic control reduces but does not eliminate type 1 complications. So you may be satisfied for a few days for your readings, but on the long run, maybe it's not helpful enough. And the intensive glycemic control is associated with weight gain in a subset of participants. Maybe they would take more insulin and also eat more, worsening lipid profiles, blood pressure, central adiposity, and inflammation, all of which may negate positive effects of improved of HbA1c. The diabetes increases the risk of early death from cardiovascular disease, as we all know. And vascular dysfunction starts early after the onset of type 1 diabetes, and it's related to metabolic risk factor, glycemic control, blood pressure, dyslipidemia. And this metabolic risk factor control is beneficial, but only partially protects against cardiovascular disease. So the recently published ADIT trial, adolescent type 1 diabetes cardiorenal intervention trial, showed that the use of MEC inhibitor and a statin over 2 to 4 years failed to change carotid intima media thickness and other cardiovascular disease risk markers in youth with type 1 diabetes. And necessity of evaluating alternative therapeutic targets to impede the development of cardiovascular disease remains a public health priority. And the insulin resistance is an important feature or a prominent feature of type 1 diabetes in adolescents and adults, even those of normal weight, not only the obese ones. And the evidence of cardiac and vascular dysfunction is already present during adolescence in type 1 diabetes. So the risk is already there and we have to handle it. So the insulin resistance has been increasingly recognized to confer high risks for a more atherogenic lipoprotein profile and microvascular and macrovascular complications in youth with type 1 diabetes and adults. So metformin, in adults you always use it, we don't, has been shown to reduce cardiovascular disease and to improve body composition in adults with type 2 diabetes. It lowers the daily insulin dose in overweight or obese adolescents with type 1 and in adolescents with type 1 with high A1C, implying improved insulin sensitivity. So we're working on the sensitivity. These studies did not evaluate whether metformin directly improves insulin sensitivity or cardiovascular disease in type 1, or whether its effects are different in normal weight versus obese patients. Normal weight patients are important to consider because both normal and obese adolescents with type 1 diabetes are significantly insulin resistant compared with body mass index matched normal glycemic peers. Yet they have a unique phenotype that differs from that of youth with type 2 diabetes. Metformin is the only oral medication approved for pediatric use in type 2 diabetes, and it remains the most widely prescribed insulin sensitizing agent. The effects of metformin in type 2 are incompletely understood. As you all know, likely mediated by mechanisms including decreasing hepatic glucose output and increasing glucose disposal in myocytes. The UK prospective diabetes study demonstrated cardiovascular benefits with metformin in adults with type 2 diabetes. However, a recent meta-analysis in children and to see how the metabolic outcomes are, they used a systematic review and meta-analysis of randomized controlled trials conducted in children age group who were diagnosed with type 1 diabetes, and they examined the effect of adding metformin as an add-on to insulin. 736 studies were screened. They had randomized controlled trials, and 325 patients were adolescents, mean age 15 years. And the results shows that the addition of metformin resulted in decreased total insulin daily dose, a reduced BMI and BMI Z-score, similar HbA1c, not much difference, and the overall evidence quality was high to moderate. Current evidence does not support use of metformin in type 1 diabetes adolescents to improve A1c. However, metformin may provide modest reduction in total insulin daily dose and BMI. A more recent study published recently in Recirculation, and this is actually the core that I wanted to present, is that metformin improves insulin sensitivity and vascular health in youth with type 1 diabetes mellitus. It helps us now, and it helps us later on to protect them. So central aortic stiffness is an early predictor of overt cardiovascular disease in adults with type 1 and type 2 diabetes, and it's reported in children and young adults with type 1 diabetes. Most previous studies applied tonometric-based methods which can underestimate central aortic stiffness. We are here more getting deeply into cardiology. And MRI imaging-derived pulse wave velocity from the flow area method offers more specific comparison of aortic extrinsic properties. Phase contrast MRI is also a technique that can non-invasively and simultaneously provide multiple direct measures of aortic health and may be more sensitive to early cardiovascular changes in type 1 diabetes than the traditional vascular measures. And phase contrast MRI has not yet been comprehensively investigated in this population, so it's something new. Now the background that, as we mentioned before, cardiovascular disease, the risk in type 1, the relationship to insulin resistance, also like in type 1 in lean and obese patients, both. And we know that metformin improves the surrogate markers of insulin resistance in type 1 diabetes, but its effect on directly measured insulin resistance and vascular health in youth with type 1 diabetes is unclear. So they hypothesized that the adolescents with type 1 diabetes have impaired vascular function and that metformin improved this insulin resistance and vascular dysfunction, both. The criteria, this is the age group of interest, 12 to 21 years, tenor stage 1 or greater, and starting puberty, diabetes duration more than a year, of course at the definitions of the American Diabetes Association, and that the patient should have had associated antibodies and insulin treatment. They did MRI for adolescents with type 1 diabetes and control, the MRI of the ascending aorta and descending aorta to assess the pulse wave velocity, relative area change, maximal and time average wall shear stress. The participants with type 1 also underwent assessment of carotid intima media thickness by ultrasound, brachial distendability by Diane pulse, fat and lean mass by dual energy X-ray absorptiometry, fasting laboratories after overnight glycemic control and insulin sensitivity by hyperinsulinic euglycemic clamp, glucose infusion rate to insulin, this is the gold standard, and adolescents with type 1 were randomized 1 to 3 months of 2,000 milligram of metformin, a little bit more than what we gave our patients, or placebo daily, after which baseline measures were repeated. The results showed that 48 type 1 diabetes adolescents aged 12 to 21 years 40% of them with a BMI above the 90th percentile for age, 56% of them female, and it included 24 non-diabetic control participants of similar age, BMI, and sex distribution in order to compare them. Type 1 diabetes adolescent demonstrated impaired aortic health compared with control. So at this early age, you can already see the impairment. And the type 1 diabetes adolescents group which received metformin showed improved glucose infusion rate to insulin and reduced weight, BMI, and fat mass. The metformin group had reduced, these are the cardiologic measurements, and they had far-wall diastolic carotid intima media thickness versus placebo. So the conclusions are that the type 1 diabetes adolescents insulin resistant, and they are insulin resistant and they have impaired vascular health compared with control. Metformin improves insulin resistance regardless of baseline BMI in lean and obese patients, weight, regardless of weight, fat mass, insulin dose, and aortic and carotid health in adolescents with type 1. And metformin may hold promise as a cardioprotective intervention in type 1 diabetes. Other outcomes were that the improvement in insulin sensitivity was not limited to obese participants, significant when assessing both per 1 kg of body weight and 1 kg of fat free mass. This is the first report demonstrating improvement in insulin sensitivity by the gold standard hyperinsulinic euglycemic clamp technique with metformin versus placebo in lean and obese youth with type 1 diabetes. In addition, to the best of our knowledge, no other pediatric or adult studies have investigated the impact of metformin therapy on aortic WSS or aortic stiffness. Now, the results may not be applicable to prepubertal youth, and the treatment duration was limited to 3 months, which is quite short. But no continuous glucose monitoring was done to repeatedly monitor blood sugars during vascular assessment, only regular labs. And not all girls were studied in the traditionally defined follicular phase because adolescents often have anovulatory irregular periods in the first 2 years after menarche, and we know that the insulin resistance may change throughout the menstrual period. I will just cut into other oral options in the pediatric age group. As we heard this morning, no one can make a lecture without talking about SGLT2 inhibitors that are coming. So just in short, you know how they work, you know that we are using them, but you also know that there's a risk of DKA, and this is of course very critical in the pediatric age group, so this is something that we have to be very careful about. Officially, it is not really used, but there are studies going on to use SGLT2, I'll finish in a minute, SGLT2 in pediatric age group, but very carefully. I wanted to present a study, but we'll keep it to the end. But it is promising, definitely. And GLP-1 agonists are also an option to be considered. Still studies are going. It's not really recommended, but it's also something that is common. And at the end, the black dress. Insulin is and will remain the simple black dress that will never be out of fashion. It can go with almost anything and remains the basis of one's wardrobe, something we learned from our wives. And just like the black dress, by simple additions or modifications, it can be adapted to nearly all occasions. The conclusions: glycemic control is most difficult during adolescence. Adolescents with type 1 diabetes are more insulin resistant than their peers, increasing their risk for cardiovascular disease. Metformin improves insulin resistance regardless of baseline BMI, weight, fat mass, insulin dose, and aortic and carotid health in adolescents with type 1, and it may hold a promise as a cardioprotective intervention for type 1 diabetes, and other agents such as SGL2 and GLP-1 inhibitors may take more significant role in the diabetic pediatric age group in the near future. Thank you.
Thank you very much, Dr. Najwa.